Welcome to the Hospital Medicine Unplugged podcast. Today, we are conducting a comprehensive clinical review of a disease state that has undergone a really significant evolution in terms of nomenclature, diagnostic criteria, and management over the last decade, axial spondyloarthritis.
It is a pleasure to be here to discuss this, and you're absolutely right regarding the evolution of the field. For a long time, the medical community operated with a somewhat narrow focus on ankylosing spondylitis, or AS.
Right.
But our modern understanding has shifted. We now recognize AS not as a standalone entity, but as the radiographic subset of a broader umbrella term, axial spondyloarthritis, or r-axSpA.
That distinction is just so critical for the clinician to understand. It is not just a semantic update. It represents a fundamental shift in how we categorize and, more importantly, when we recognize this pathology.
Exactly.
So when we use the term ankylosing spondylitis, we are referring specifically to radiographic axial spondyloarthritis, or r-axSpA. These are the patients who have definitive radiographic sacroiliitis visible on plain X-rays.
Precisely. We are talking about structural damage that is, visible to the naked eye on a light box. And then we have the other side of that coin, non-radiographic axial spondyloarthritis, or nr-axSpA. These patients share the same clinical presentation, the same symptom burden, and the same genetic associations, but they lack that definitive structural damage on plain radiography.
And that's a key point.
It is.
Yeah.
It is crucial to emphasize that the disease burden, the pain, the stiffness, the functional impairment is similar between these two groups. The distinction is largely an imaging finding, not necessarily a difference in patient suffering.
It's essentially a difference in time, isn't it? Or perhaps a difference in the sensitivity of our tools.
That's a great way to put it.
If we wait for the X-ray to turn positive, we are waiting for the damage to become permanent. Realizing that this is a spectrum has huge implications for early diagnosis.
It does.
And the epidemiology data, well, it paints a concerning picture regarding our ability to identify these patients in a timely manner. The data indicates a diagnostic delay averaging 6.7 years from symptom onset to diagnosis.
That 6.7-year delay is a staggering figure. Think about that number for a second. 6.7 years?
It's incredible.
That is not a delay. That is an era. That is someone spending their entire 20s in pain, being told it is just a strain or poor posture or mechanical back pain. When you consider the pathophysiology, which we will get into, that is nearly 7 years of unchecked inflammation. This is the critical window where we might have the opportunity to prevent disease progression and structural damage. By the time radiographic changes are visible for a diagnosis of classic AS, we are already looking at established damage.
It effectively means that for nearly a decade, the patient is burning, and we only acknowledge the fire once the house is charred. We need to unpack why this happens. Is it because the criteria were wrong? Or is it because the disease effectively camouflages itself as mechanical back pain? I suspect it's a bit of both.
I think you're right.
Let's delve into the epidemiology and demographics to understand who these patients are. Globally, the prevalence of axial spondyloarthritis ranges from, 0.3% to 1.4%, and here in the United States, we are looking at a prevalence of approximately 1%.
Which is not insignificant. 1% of the population means this is a condition every hospitalist and internist will encounter, likely frequently, whether they recognize it or not.
Absolutely.
And it is strongly correlated with the prevalence of HLA-B27 in the general population. In terms of the patient profile, this is a disease of young adults. The disease typically emerges in the third decade of life.
That's a key point.
It is. In fact, over 80% of patients develop their first symptoms before the age of 30.
And that age of onset is a key clinical red flag. Back pain in a 25-year-old should trigger a different differential diagnosis than back pain in a 65-year-old.
It absolutely should.
But historically, we have also had a massive blind spot regarding gender. We used to think of this as a predominantly male disease.
That is correct. Historically, ankylosing spondylitis was taught as having a male predominance with a ratio of roughly 2 to 1 or even 3 to 1. It was viewed as a man's disease.
Right.
However, when we look at the broader spectrum of axial spondyloarthritis, particularly the non-radiographic subset, the sex distribution is actually equal.
Which suggests that the male disease stereotype was largely an artifact of our diagnostic methods.
Exactly.
Men are more likely to develop the radiographic changes, the fusion earlier, so they were caught by the modified New York criteria. Women who might present more often with non-radiographic disease were simply being missed
Or delayed. They were delayed because we were relying on X-rays rather than MRI.
Exactly. We were essentially gaslighting female patients for decades.
It's a harsh way to put it, but it's not wrong. They had the pain, they had the stiffness, they carried the gene, but because their bones had not literally fused yet on a plain film, we told them they did not have the disease.
And the MRI now captures those non-radiographic cases much more evenly across genders.
It does. It implies that the underlying prevalence is likely much more balanced than we previously believed. This is a vital takeaway for the hospitalist or primary care physician. Do not rule out spondyloarthritis simply because the patient is female.
Okay, let's shift to the pathophysiology. This is, a complex interplay of genetics and immune dysregulation. We have already mentioned HLA-B27. It remains the strongest genetic risk factor present in approximately 80 to 90% of patients with ankylosing spondylitis.
The association is incredibly strong, arguably one of the strongest in rheumatology. Yet the precise pathogenic mechanism of HLA-B27 is still a subject of intense research. It is not as simple as you have the gene, you get the disease, because only a small fraction of HLA-B27 positive individuals actually develop AXIOPA.
So how is it thought to work?
Well, there are three main hypotheses that currently dominate the literature regarding how this molecule drives disease. The first is the concept of arthrodygenic peptide presentation.
This is the idea that the HLA-B27 molecule presents specific self-peptides to CD8 plus T cells, triggering an autoimmune response due to molecular mimicry, essentially confusing the immune system.
Correct. The theory is that the HLA-B27 molecule has a specific binding pocket that prefers certain peptides, perhaps from bacteria, perhaps from self-tissue, that look very similar. The immune system attacks the foreign invader, but ends up attacking the host's own connective tissue.
Okay, so that's one theory. What's the second hypothesis?
The second involves homodimer formation.
Homodimer formation.
Yes. We usually think of HLA molecules presenting antigens, but in this case, the theory is that cell surface HLA-B27 heavy chains form dimers pairs that bind to and activate innate killer immunoglobulin-like receptors on CD4 plus T817 cells and other immune cells.
So it's bypassing the standard antigen presentation pathway entirely.
It is. It is essentially the molecule misbehaving structurally on the cell surface.
And the third hypothesis relates to protein misfolding. And this one seems to gain a lot of traction when we talk about cellular stress.
It does. Imagine the endoplasmic reticulum as a protein factory. Usually it folds proteins perfectly. But HLA-B27 is like a complex origami piece that keeps getting jammed in the machine. It has a tendency to misfold within the endoplasmic reticulum.
And this misfolding causes a factory backup, so to speak, cellular stress.
Exactly. The cell panics and hits the emergency alarm, which in this case is the unfolded protein response, or UPR. This alarm screams for inflammation. Specifically, this cellular stress response leads to the upregulation of pro-inflammatory cytokines, specifically increasing IL-23 expression.
And that brings us to the central inflammatory highway of this disease, the IL-23-IL-17 axis.
This axis is critical. It is the engine of the inflammation, but it is not just the genetics. It is the interaction with environmental factors.
Right.
We see evidence of gut dysbiosis and bacterial translocation through disrupted intestinal barriers. This, combined with mechanical stress of the entheses, the insertion sites of tendons and ligaments, creates a perfect storm.
So you have these factors recruiting neutrophils and activating the cytokine cascade, IL-23, IL-17, and TNF-alpha. And the result is enthesitis. I want to pause on enthesitis because for a generalist, we often think of arthritis as synovitis inflammation of the joint lining, like in rheumatoid arthritis. But this is different.
It is fundamentally different. Enthesitis is the hallmark pathological process of spondyloarthritis. Unlike rheumatoid arthritis, which is primarily a synovitis, this starts at the enthesis, where the Achilles tendon hits the heel or where the annulus fibrosus attaches to the vertebral body.
And what happens there?
The inflammation there leads to erosions, but uniquely to this condition, it also triggers pathological new bone formation.
That is the paradox, isn't it? In rheumatoid arthritis, the bone gets eaten away. In spondyloarthritis, the bone gets eaten away, but then the body tries to repair it aggressively and lays down new bone.
Exactly. That is what eventually leads to the syndesmophytes and ankylosis, or fusion, of the spine. It is a fascinating and destructive process. Inflammation leading to ossification. The body's attempt at repair essentially welds the skeleton together.
Now, translating this to the bedside, let's discuss the clinical manifestations. We established that back pain is the primary symptom, but it is not just any back pain. It is inflammatory back pain, or IBP.
Right.
If I am a hospitalist admitting a patient for something else, how do I distinguish this from the mechanical back pain that, 90% of the population complains about?
Distinguishing IBP from mechanical back pain is perhaps the single most important clinical skill in identifying these patients. Inflammatory back pain affects over 80% of them. The classic features are a gradual onset before the age of 45.
Okay.
But the money shot, clinically speaking, is the morning stiffness. We're talking about stiffness lasting more than 30 minutes.
And the response to activity is the inverse of mechanical pain.
It is.
Patients with IBP report improvement with exercise and a lack of improvement, or even worsening with rest. They often wake up in the second half of the night due to pain.
Correct. If a young patient tells you their back hurts more when they lie down and feels better when they get up and move, that is a high sensitivity trigger for suspecting spondyloarthritis. It is the gel phenomenon.
The gel phenomena.
The inflammatory cytokines settle when immobile, causing pain. Movement increases blood flow and flushes the area. If a 25-year-old tells you, I have to get out of bed at 3 a.m. to walk around my living room just to relieve the pain, you essentially have your diagnosis.
Wow.
Forget the MRI for a second. That history is the red flag.
Beyond the spine, we must look for the extra-articular manifestations, or EAMs. These are not rare occurrences. They are common and clinically significant. And for the hospitalist, these might actually be the reason for admission.
They absolutely might be. The most frequent EAM is acute anterior uveitis, which has a lifetime prevalence of 25 to 30% in these patients.
A quarter to a third of all patients.
Yes. It typically presents unilaterally with abrupt onset, pain, photophobia, and visual impairment. If a patient has a history of iritis or uveitis and comes in with back pain, the probability of r-axSpA skyrockets.
Then there is the gut involvement. Inflammatory bowel disease, or IBD, has a prevalence of 5 to 10% in this population.
And interestingly, Crohn's disease is more common than ulcerative colitis in this context. Furthermore, even in patients without overt IBD, studies show that microscopic gut inflammation is detected in approximately 50% of r-axSpA patients.
Half of them.
Yes. It reinforces that gut-joint axis we discussed in the pathophysiology.
Now, you might be thinking, I'm a hospitalist, I treat pneumonia and heart failure, why do I care about chronic back pain? And here's why. You are going to see this patient for uveitis.
Right.
Or you are going to admit them for a restrictive lung disease workup. Or perhaps a conduction abnormality.
Indeed. Cardiovascular involvement can manifest as aortic valve insufficiency or conduction defects. We see VLOCs, we see aortitis. Pulmonary issues often present as restrictive lung disease, not necessarily due to parenchymal disease, but due to chest wall involvement and rigidity-limiting expansion.
So you could be the one to finally connect the dots.
You are the safety net that catches the diagnosis missed for the last 6 years because you are seeing the systemic fallout.
So we have a patient with inflammatory back pain and perhaps a history of uveitis. How do we formally diagnose them? We have 2 main classification systems. The older one is the modified New York criteria.
The modified New York criteria is the traditional standard for ankylosing spondylitis. However, its major limitation is right in the name. It requires definitive radiographic sacroiliitis.
So it's a late-stage marker.
By definition, it only captures late-stage disease where structural damage has already occurred on X-ray. Relying on this is what caused the diagnostic delays of the past.
Which brings us to the ASAS classification criteria from 2009, designed specifically to address that gap and detect early disease. This applies to patients with back pain for 3 months or longer with an onset before age 45.
The ASAS criteria are essentially split into 2 arms to capture the full spectrum. The imaging arm requires sacroiliitis on radiography or MRI, plus at least one other SPA feature.
And this is where MRI is a game changer.
It is. It allows us to see active inflammation bone marrow edema before cortical destruction occurs.
And the clinical arm allows for diagnosis even without positive imaging, provided the genetic risk is there.
Correct. This requires the patient to be HLA-B27 positive, plus having at least 2 other SPA features.
And what are those features?
Those SPA features include the things we've discussed. Inflammatory back pain, arthritis, enthesitis, dactylitis, uveitis, psoriasis, IBD, a good response to NSAIDs, family history, or elevated CRP. The sensitivity and specificity are both above 80%.
Once we have a diagnosis, we need to monitor disease activity. The gold standard has shifted from the BASTI to the ASTIs.
It has. The BASTI, or Bath Ankylosing Spondylitis Disease Activity Index, is purely patient-reported. It is subjective. How do you feel on a scale of 1 to 10?
Right.
The ASTAS, or Ankylosing Spondylitis Disease Activity Score, is preferred because it incorporates objective markers of inflammation. It combines patient-reported outcomes regarding pain and stiffness with acute phase reactants. specifically CRP or ESR.
So it's a more complete picture. The SDS categorizes disease states into inactive, less than 1.3, low, high, and very high, greater than 3.5. This allows for a treat-to-target approach similar to what we see in diabetes or hypertension.
Exactly. We aim for inactive disease. A clinically important improvement is defined as a decrease in the score of 1.1 or more, while a major improvement is a decrease of 2.0 or more.
Okay, so let's move to treatment and management. We start with non-pharmacologic management. This is not just an add-on, it is foundational.
It is. Physical therapy and structured exercise are non-negotiable. We need to encourage stretching, strengthening, and swimming to maintain mobility. And smoking cessation is absolutely crucial.
Why smoking in particular?
Smoking is a strong predictor of worse functional outcomes and radiographic progression. It's an independent risk factor for more severe disease.
For pharmacologic therapy, the first line remains NSAIDs. But I want to clarify something here. In many conditions, we use NSAIDs purely for analgesia. Is that the case here?
Not entirely. NSAIDs are the cornerstone, but we use them differently. The guidance here is specific. Continuous use is preferred over on-demand dosing for better symptom control in active disease.
And does that affect progression?
There is some data suggesting continuous use might retard radiographic progression, though that is debated. However, we know that less than 25% of patients achieve complete symptom control with NSAIDs alone.
So for the majority, NSAIDs are not enough. When they're inadequate, we escalate to biologic DMARDs. The traditional first choice has been TNF inhibitors.
The TNFi class includes adalimumab, etanercept, infliximab, golimumab, and certolizumab. They are highly effective. The ACES-20 response, which is a 20% improvement criteria, is roughly 58 to 64% compared to placebo.
And critically,
They are associated with a 50% reduction in radiographic progression.
but failure rates exist. 13 to 68% of patients experience inadequate response or loss of response over time, often due to anti-drug antibodies. This is where the IL-17 inhibitors come in.
That's right. The IL-17 inhibitors, secukinumab, ixekizumab, and the newer bimekizumab have shown efficacy comparable to TNF inhibitors. Bimekizumab is interesting as it is a dual inhibitor of IL-17A and IL-17F.
One safety note on IL-17 inhibitors regarding the gut. We need to be cautious in patients with IBD.
Yes, and this is a critical board question and clinical safety point. There are rare cases of incident IBD associated with IL-17 inhibition. So if a patient has existing Crohn's or ulcerative colitis, a TNF inhibitor, specifically a monoclonal antibody like infliximab or adalimumab, is generally preferred over an IL-17 inhibitor.
So you don't want to flare the gut to fix the back.
You do not.
We also now have JK inhibitors approved for AS as of 2022, such as tafasitinib and upadacitinib.
The JJK inhibitors offer the advantage of oral administration, which some patients prefer over injections or infusions. Efficacy is similar to biologics. However, we must be mindful of the safety warnings from the FDA and EMA regarding cardiovascular events, thrombosis, and malignancy, largely extrapolated from rheumatoid arthritis data.
I want to touch on what is known as the IL-23 paradox. We discussed in the pathophysiology that IL-23 is a key upstream cytokine. Logic would dictate that blocking it would help.
This is the plot twist of the century in rheumatology. We have the genetics screaming IL-23. We have the mouse models screaming IL-23.
But in humans?
But when we gave the drugs to humans with spinal disease, nothing. It failed.
Why? That seems to defy the basic science we just laid out.
It suggests the hit-and-run mechanism. IL-23 might light the match, but IL-17 is the forest fire. By the time the patient sees you, putting out the match doesn't stop the fire.
So IL-23 might be more important for initiation.
That's the theory. It might be important for the initiation of the disease, but once the downstream inflammation is established in the axial skeleton, it becomes IL-17 driven and independent of IL-23. It is a fascinating disconnect between mechanism and treatment.
So the guideline approach is generally start with NSAIDs. If that fails, go to TNF or IL-17 inhibitors. If those fail, switch within class or move to JAK inhibitors.
That is the standard algorithm.
Finally, let's look at prognosis and complications. We are worried about structural progression.
Progression is variable. The strongest predictor of developing new syndesmophytes is the presence of baseline syndesmophytes. Essentially, damage begets damage.
And other risk factors.
Other risk factors include early hip involvement, smoking, persistently elevated CRP, and male sex.
And we must mention bone health. There is a specific paradox here. These patients are forming new bone fusion, but they are also losing trabecular bone quality.
Correct. Osteoporosis occurs in up to 10% of patients. It is due to a combination of spinal rigidity, leading to a lack of mechanical load-stress shielding, and the systemic effects of chronic inflammation. This creates a high risk for vertebral fractures.
And the clinical pearl here is high suspicion.
Absolutely. If a patient with AS presents with new neck or back pain, even after minor trauma or no reported trauma, you must evaluate for a fracture. The fused spine acts like a long bone. It snaps like a chalk stick. These fractures can be unstable and devastating.
Functional decline is also a major concern, and it correlates directly with those disease activity scores we discussed.
Yes, higher ASTA scores predict greater disability. This reinforces the need for aggressive management to keep inflammation low.
To synthesize what we have covered today, we have moved from a radiographic-only view of ankylosing spondylitis to the broader spectrum of axial spondyloarthritis. This shift is essential to reducing that 6.7-year diagnostic delay.
Identifying inflammatory back pain patterns early is the key to closing that gap. We need to be vigilant, utilize MRI when X-rays are negative but suspicion is high, and monitor our patients using objective tools like the ASTABUS.
And we treat to target. We do not accept low-grade pain as a baseline. We aim for remission to preserve function and preventing that structural lockdown of the spine.
It connects back to the bigger picture of improving long-term quality of life.
Here is a final provocative thought for our listeners to consider. We know that early biologic therapy reduces inflammation and improves symptoms. However, the debate continues in the literature regarding whether it definitively halts radiographic progression in the long term. We are effectively betting that suppressing the inflammation early will stop the bone formation, but the decoupling of inflammation and ossification remains a subject of intense study. It challenges us as physicians to weigh aggressive early intervention against long-term risks, even when the promise of completely arresting structural damage is not yet 100% guaranteed by the data.
It is this central question remaining in the field.
Thank you for joining us on this deep dive into axial spondyloarthritis.
Thank you.
This has been Hospital Medicine Unplugged.